Welcome to our fourth annual St. Elizabeth's Parkinson's Disease Symposium. Today we'll be going through the spectrum of Parkinson's disease. I'll be presenting along with my colleagues Keith Ciccone and Dr. Okeanis Vaou.
It is with great pleasure I introduce Dr. Anna Hohler. Dr. Hohler joined St. Elizabeth's Medical Center from Boston Medical Center in November of 2017 as the first female chair of neurology. She is a professor of neurology at Tufts University School of Medicine. She also served as Director of Medical Student Education for Stewart Healthcare. She is the Assistant Dean, St. Elizabeth's Affiliate Site for Boston University School of Medicine. Dr. Hohler completed her undergraduate and her medical degree at Boston University in the 7-year accelerated medical program. Then she completed her internship and residency in neurology at Madigan Army Medical Center in Tacoma, Washington. After 8 years of distinguished military service in the United States Army, she was honorably discharged, having received the rank of major. Then she completed a fellowship in movement disorder at Boston Medical Center. Dr. Hohler received numerous awards and recognized throughout her career, including Army Commendation, Army Achievement, and Meritorious Medical Service Awards for academic and leader excellence. She received the Colonel Skelton Award for Top Resident at Madigan Army Medical Center, the Academy of American Neurology National Outstanding Teacher Recognition Award, the Stanley Robinson Award, the highest teaching award honor at Boston University. In 2016, she received the Burton Standock National Neurology Educator of the Award by the Mayo Clinic. Dr. Hohler has a national and international reputation in lectures on neurology, movement, and autonomic dysfunction. It is my pleasure again to introduce Dr. Hohler.
Welcome to the presentation on early Parkinson's disease evaluation and management. Today, I'll be discussing the signs and symptoms of Parkinson's disease, what causes Parkinson's disease, and how to manage early Parkinson's disease. Nearly 1 million people in the United States are living with Parkinson's disease, and this is expected to rise to 1.2 million by 2030. Approximately 60,000 Americans are diagnosed with Parkinson's each year, and more than 10 million people worldwide are living with Parkinson's disease. The incidence of Parkinson's disease increases with age, but an estimated 4% of people with Parkinson's are diagnosed before the age of 50. Men are 1.5 times more likely to have Parkinson's disease than women. There are medical and surgical therapies that are combined with other types of therapies and conservative treatments to improve the course of patients over the spectrum of their disease. Early in the disease process, individuals typically suffer more from motor symptoms, and later in the disease process, non-motor symptoms become more prominent. So early signs and symptoms of Parkinson's disease include things like tremor, small handwriting, otherwise known as micrographia, loss of smell, otherwise known as anosmia, trouble sleeping, and in particular early morning awakening and acting out one's dreams, slowness of movements, constipation, low or soft voice, decrease in facial animation, dizziness related to drops in blood pressure, and stooped posture. The diagnosis of Parkinson's disease is made based on these signs and symptoms from the neurologic exam. The neurologist rules out other causes of Parkinson's disease or Parkinson's mimickers. There's typically laboratory testing and imaging that's performed, and then a trial of medication therapy. The neurologist or movement disorder specialist will take a history to determine these types of symptoms that I just mentioned. These will include things like tremor, slowness, stiffness, and also walking difficulties. They'll also perform a neurological exam looking at cranial nerve issues, mental status, reflexes, sensation, and coordination. From there, they'll be able to determine whether or not somebody has some of the elements of Parkinsonism. These may be slowness, stiffness, tremor, but they could be related to other causes other than Parkinson's disease. So it's important to rule out these other causes before a diagnosis is made. Other things that can look like Parkinson's mimickers include things like strokes, medication-related effects from medications that can be used for the stomach or medications that can be used for hallucinations. Trauma and repetitive head trauma can give people symptoms of Parkinsonism. People can have enlargement of their fluid-filled spaces in the brain, which can make them look like they have Parkinson's. And they can have things that are similar to Parkinson's in the family of Parkinson's, but have a little bit of nuances. So things like multiple system atrophy, where people have more blood pressure issues, cortical basal degeneration, where they have more focal dystonia, or Lewy body dementia, where memory and cognitive issues are a prominent feature as well. Sometimes things like thyroid dysfunction or heavy metal toxicity from copper and manganese may make somebody look like they're Parkinsonian. So the neurologist and movement disorder specialist will typically order some lab testing to rule out these things, such as a complete metabolic panel, thyroid testing, heavy metal testing, vitamin levels. In addition, the neurologist will classically order imaging. This may include a head CT or an MRI to rule out structural issues. In some cases, a DAT scan or dopamine scan may be useful to help determine if somebody does have decreased dopamine related to a Parkinsonian syndrome. Here you see some images of somebody who's had a DAT scan who has Parkinson's disease. In the top left corner, you see bright yellow signal on one side of the brain and a lower signal on the other. The lower signal part of the brain indicates an area where dopamine has been decreased. As you follow the pictures from right to bottom left to bottom right, you see a decrease in the color, which is the dopamine level in the brain. This imaging shows the progression of the dopamine depletion that we see in patients who have Parkinson's disease over time. The DAT scan can help in terms of diagnosis and can help in terms of clarifying nuances in cases where the diagnosis may be difficult to make. Not every institution does have a DAT scan, but we are fortunate at St. Elizabeth's to have this available. When we think about what causes Parkinson's disease, this helps us to potentially think in the future about ways of treating and perhaps eradicating the disease. So there are a number of different risk factors for Parkinson's. These include increased age, genetics, environmental exposures, medication-related, and head injury. Genetics are important in terms of 15% of people with Parkinson's disease do have a family history that's identified. Parkinson's disease mutations have been identified in LRRK2 mutations, PARK7, GBA, PINK1, Parkin, SNCA, and VP35 genes. Mutations in some of these genes may also play a role in cases that appear to be sporadic. Fortunately, right now we are participating in a study looking at genetic evaluation, otherwise known as PD generation, and this is offered free of charge through our study in collaboration with the Parkinson's Foundation. There are also environmental exposures that may increase our risk for developing Parkinson's disease and Parkinsonism. I mentioned before copper and manganese. Mercury can also be associated with Parkinsonism, and individuals exposed to herbicides and pesticides, in particular paraquat, that farmers use, can have increased risk of Parkinson's. In addition, those who have been exposed to Agent Orange through their military service, there is a clear association with increased risk of Parkinson's disease, and this is a VA disability-associated type of finding. So in those cases, we want to make sure that people receive the VA benefits they deserve. In addition, first responders, such as firemen, may be at higher risk for Parkinsonism related to carbon monoxide exposure and styrene exposure. In addition, well water consumption and chemical dry cleaning can also increase risk for Parkinson's. Here's an article that describes some of the increased risk in carbon monoxide intoxication-related Parkinsonism that individuals who have toxic exposures can suffer from. In addition, sometimes people can get Parkinsonism related to medications that are prescribed to them, and these include things like Abilify, Haldol, which are medications used to treat hallucinations, and Reglan, which can be used for people who are having problems with their gastric motility. If people are on these medications, decreasing them or stopping the medications may help reduce symptoms of Parkinson's. In addition, people who have suffered from chronic traumatic encephalopathy may be at higher risk for Parkinson's and Parkinsonism, and so we recommend that people try and avoid situations where they may have increased risk of head trauma. So how do we reduce our risk for developing Parkinson's disease? One of the things we might want to do is if we have well water, we might want to have the water tested to make sure that we don't have toxins that we're consuming. We want to try and avoid chemical exposures. We want to try and avoid additives and preservatives in our food. We want to try and avoid head trauma and medications that may reduce our dopamine levels. Once we have a diagnosis of Parkinson's disease, we want to establish a good foundation for healthy lifestyle. These include a schedule, an exercise routine, healthy diet, optimization of hydration, sleep hygiene, stress management, and socializing. The schedule is very important. Individuals who do best with their Parkinson's are ones who have a routine. Getting up at the same time every morning and going to bed at approximately the same time every day, regardless of weekdays or weekends, usually sets you up for success. This, combined with taking medications within 15 minutes of scheduled times and eating 3 meals a day at regular times, helps to ensure that you have a steady amount of time that you have your medications in your system before you consume your meals. You shouldn't eat until 30 minutes after you've taken your medications to ensure that the medication has been absorbed fully. This is especially important for carbidopa-levodopa medication. What exercise is ideal for Parkinson's? Patients with Parkinson's should have a tailored exercise plan that's developed with a neurologically trained physical therapist. We get this started early on once people are diagnosed with Parkinson's to ensure them success. Periodically, if people develop new symptoms, we may have them reevaluated by the physical therapist to adjust the prescription exercise program as required. Exercises should include stretches, balance, trunk strengthening exercises along with cardio. Some organized exercise programs such as walking, biking, tango, tai chi, and boxing have all shown benefit in terms of slowing progression of Parkinson's disease, so we encourage these activities as well. In addition, speech therapy with the LSVT or Big and Loud program and singing courses and singing programs can be very useful to help maintain voice, volume, and articulation. And then occupational therapy and working on activities of daily living, hand use activities in particular, working on our handwriting and combating micrographia are also very useful. There are a variety of online programs that can be utilized to help with benefiting that as well. A healthy diet helps to ensure that the gut is properly functioning at its best, so regular meals are ideal. We also want individuals to utilize a Mediterranean diet, and so this is high in olive oil, lean meats, and large amounts of veggies. It's also important to add salt to your diet if your blood pressure is low, and your physician can give you some guidance about this. And you should take a multivitamin and additional vitamins as needed should your levels be low, in particular with vitamin D, B12, and iron should those be found on your blood tests. Hydration is also key, not just in terms of proper gut functioning, but also in terms of medication absorption. Ideally, you should be drinking at least 60 ounces of good fluids a day. This ensures optimized cerebral perfusion or brain blood flow and allows your medications to be absorbed. We recommend taking in 40 ounces before noon and another 20 ounces before 6 p.m. If you take your fluids and consume them primarily before 6 p.m., it should not affect your frequency of urination during the night. The good fluids are water, juice, milk, and decaffeinated drinks. Other drinks such as soda, coffee, tea, and alcohol do not count towards your 60 ounces a day. Sleep hygiene is crucial for starting the day right with Parkinson's. You should try and, as I said, wake up at the same time every day and go to bed at the same time every day. Try not to drink a lot of fluids after 6 p.m. to help reduce your need for having to get up and going to the bathroom at night. Try and lift your legs up in the evening while you're watching TV. This also helps to mobilize your fluids before you go to bed. Your bed should be comfortable, the room should be a little bit cool, and the bedding should be appropriate. Also, make sure your path to the bathroom is well lit so you don't have an increased risk for falls at night. Stress management is also crucial in terms of Parkinson's disease. Depression and anxiety both contribute to worsening Parkinson's symptoms. Optimize your therapies for these issues, and that will help you do better overall. We often recommend the Calm, C-A-L-M app to be downloaded to help with breathing exercises, and we frequently make referrals to psychiatry and to therapists if there is a need for help with depression or anxiety. And then socializing will help to enable you to interact well and also to help to slow progression of disease with Parkinson's and also cognitive issues. You want to socialize with friends and family, and you want to have a strong support network. In addition, Parkinson's support groups provide information and support as you're progressing through the stages of the disease. And socializing decreases the likelihood of progression. So how is Parkinson's disease transmitted? We know that Parkinson's disease affects the dopamine levels in the brain, and we also know that there's a progression through the base portions of the brainstem, up through the motor cortex and then to the cortex. Pathologically, we see Lewy body inclusions in the areas of the brain affected in patients with Parkinson's disease. So here we go through Brack's pathologic stages of Parkinson's disease. In stage 1, individuals have affected areas in the brainstem, and that can give them troubles with constipation and decrease in sense of smell. In stage 2, they can have development of some motor symptoms as well, as we have progression to the motor cortex. In addition to that, in later stages, individuals have progression of the Lewy body spread to the cortex, and they have more cognitive difficulties. So our goal is to try and stop slow progression of Parkinson's and eventually cure the disease. What we know is that Parkinson's disease also affects areas outside of the brain. So the gut can have changes in it related to Parkinson's disease. And in fact, patients who are studied who have Parkinson's disease have a change in their gut flora that's different from people who don't have Parkinson's disease. So this is being studied in more detail to try and better understand how we may be able to detect Parkinson's symptoms earlier and be able to slow the progression. Some of the studies looking at Parkinson's disease have looked at alpha-synuclein transmission. And so we find that the alpha-synuclein can be affected in the stomach and the intestines, and there may be some transmission through the vagus nerve to the spinal cord. Individuals who had their vagus nerve lanced or cut didn't have progression of their disease to the spinal cord and then upwards to the brainstem. So there may be some future abilities to be able to slow down the progression in this manner. How do we treat Parkinson's now? In general, we're looking at improving the neurotransmitters in the brain. And so this involves things like improving dopamine levels to improve motor function, improving norepinephrine levels to improve autonomic functioning, improving serotonin to improve mood, and increasing acetylcholine to improve cognition. So all of these can be affected in Parkinson's in individuals, some more than others, and at different stages of the disease process. Some people have some portions affected, some people have all portions affected, because Parkinson's disease is an individualized disease. Everybody has a little bit of a different picture, and everybody has a little bit of a different treatment regimen as a result. So we think about increasing some of these neurochemicals to help the body function better. And if you look at this diagram, it shows the dopamine in the vesicles in the neuron, then going across the synaptic cleft and activating the dopamine receptors on the next receptor areas. What we want to do is try and increase dopamine levels overall, decrease the breakdown of dopamine, or increase the activity of dopamine receptors. And this can be accomplished by a variety of different medication classes. Dr. Vaou is going to go through this in more detail in her discussion, but briefly, we have carbidopa, levodopa, the dopamine agonists, the MAOB inhibitors, the COMT inhibitors, istradefenil, and amantadine. And we utilize these medications in different doses and at different times to help benefit the individual in terms of their symptoms and their disease process. We determine what medications to initiate based on the symptoms an individual has, their activities of daily living and what goals they're trying to accomplish, the age of the patient, the other medical issues the patient has and other medications they may be taking, and the goals overall of care. So our plan is to provide what we call rational polypharmacy. We use the lowest doses of medications that we need in combination to produce the maximum amount of benefit for individuals. We're trying to keep people at 85 to 90% of perfect. So what we want to do for individuals who are starting on this pathway is to give them a lot of education about Parkinson's disease and signs and symptoms, help them to better understand how they can form a great foundation in terms of healthy habits, give them an idea about medications and how we're going to be utilizing them to help them, and also introduce other ideas about things like surgical interventions and future therapies that they may be interested in participating and utilizing. Briefly, for surgery, right now we have the option of deep brain stimulation, and we can also use focused ultrasound thalamotomy for those just related to tremor. Dr. Vaou is again going to talk about this in more detail, but just to highlight, deep brain stimulation enables us to provide electrical signaling to the brain to be able to reduce motor symptoms. In addition, typically we're able to reduce medications as a result as well. In terms of new and future treatments, there are a variety of different research topics that we're working on right now and different therapeutic interventions. These include biomarker monitoring and intervention, imaging studies, blood tests, spinal fluid testing, evaluation of the gut microbiome to be able to better understand the initial stages of Parkinson's disease and how we can slow those down, the effect of peripheral electrical stimulators that might interrupt some of this negative signaling that the patient is getting from the brain and help to improve symptoms such as tremor, alpha-synuclein treatments to help decrease the alpha-synuclein accumulation in individuals, micro-targeting and sensing deep brain stimulation to help provide motor and perhaps non-motor improvements in individuals, stem cell treatments, and viral vector therapy. So we know that with Parkinson's disease, the brain produces a lot of the symptoms that we're seeing, but there are other areas of the body that that are involved. And so our goal is to try and better understand that to make your life better. So we reviewed signs and symptoms of Parkinson's today, what causes Parkinson's disease, and how to manage early Parkinson's disease. This is our group at St. Elizabeth's. We're happy to see you in follow-up or see you as a new patient. Our number is 617-789-2375. Thank you for your participation.
It is my pleasure to introduce Dr. Okeanis Vaou. Dr. Vaou is the Director of Movement Disorders and Deep Brain Stimulation here at St. Elizabeth's Medical Center. She received her medical degree from Semmelweis University of Medicine in Budapest, Hungary. Dr. Vaou completed her neurology residency at New York Medical College and served as the chief resident. Then she pursued fellowships at Boston University School of Medicine in movement disorders as well as sleep medicine. Her expertise in treating patients with Parkinson's disease, atypical Parkinson's, essential tremor, and other movement disorders. She is also her expertise in treating patients with Parkinson's disease, atypical Parkinson's, essential tremor, and other movement disorders. She is also a board-certified sleep specialist and treats sleep disorders in Parkinson's disease. In addition to patient care, Dr. Vaou is actively involved in medical student education. She currently serves the Neurology Medical Student Site Director for St. Elizabeth's and oversees the Tufts and BU School of Medicine medical education, as well as the BU School of Medicine PA student programs. Dr. Vaou has participated in clinical research evaluating novel pharmaceutical agents and patient education in Parkinson's disease. She is very involved in raising awareness of early Parkinson's disease and deep brain stimulation. It is my pleasure to introduce Dr. Vaou.
Thank you, Keith, for this wonderful and kind introduction. Thank you all for being here. After Dr. Hohler's talk on early Parkinson's, I'd like to talk a little bit about mid-stage Parkinson's and therapy. So as you may know, Parkinson is, we divide Parkinson into stages. Stage 1 is usually when one side of the body is affected. Moving on as it progresses into stage 2, where it affects the other part of the other side of the body. Then in stage 3, which is when we are talking about intermediate stage or mid-stage Parkinson's, we're talking about some trouble with balance and some problems with walking, but overall intact functioning. Then stage 4, walking and standing is difficult, but without help. And in stage 5, most patients are wheelchair bound and have difficulty walking. If you see in this slide, the motor symptoms are the ones that are defining the 3 stages of Parkinson's disease. So we have early, mid, and late, and I will be focusing today this talk on mid-stage Parkinson's disease. So what really is mid-stage Parkinson's disease? When do people enter this stage? Mostly when you feel that your motor symptoms are suboptimally treated. In other words, there's good control, but not as good as you used to have in the past. And a lot of the patients are starting to have significant off time where they feel that their medications are no longer working, or increased incidence of dyskinesia where they have those extra dance-like movements, and a lot of those ons and offs and fluctuations in their motor symptoms. If you look at this slide, this very nicely illustrates the different symptoms that move along as the disease progresses. So early disease, we have the tremor, the stiffness, and the slow movements. But as we move into mid-stage Parkinson's disease, that's when the fluctuations, the motor fluctuations start entering. We notice those dyskinesias, some postures of your body that may be different, maybe more stooped posture, etc. Along with that, we also notice some of these non-motor symptoms start prevailing, such as blood pressure. The blood pressure may be dropping. Some urinary symptoms, you might find that you need to rush to the bathroom more frequently to urinate. Some mild cognitive impairment, some visual hallucinations might start at this stage. Now, depending on the stage that we're in, we make decisions about therapy. In mid-stage, where we have mostly fluctuations and dyskinesias, we know that symptoms are not adequately controlled. So what do? We adjust our medications depending on those symptoms. One of the solutions would be deep brain stimulation, so that could be a good option. However, that is not the only option. First of all, we want to try to optimize therapy. So in moderate Parkinson's disease, we try to recognize when the patient is wearing off. So how many hours of off time does that patient have? And we're trying to reduce those periods of off time by adjusting medication. Sometimes we add medications to levodopa, carbidopa, so that we boost, so to speak, the action of levodopa. So how do we manage off times? So this is the art of treating someone with Parkinson's disease in mid-stage Parkinson's. There's 2 different approaches. You either want to use rescue medications, or we want to increase levodopa action. And last but not least, deep brain stimulation. So for use of rescue medications, we know that in the recent years, we've started noticing some of those medications that someone can take as needed. It's almost like someone has a headache, so you take a medication, a Tylenol, to stop the pain. So when someone's off, they take this medication, and it's a rescue medication that kicks in very fast and helps control that off state and their motor symptoms. There's the inhaled levodopa, also known as Embracia. There's a sublingual Apomorphin, which is the brand name is Kinemobi. And there's also the injectable Apomorphin called Apican. Formulations to increase the levodopa action, we have been using for quite a few years now what we call COMT inhibitors. that class of medication. There's also now some new ones, such as the long-acting COMT inhibitor called Ongentys. We may want to try decreasing the dosing interval, in other words, taking carbidopa levodopa more frequently. We're trying to add dopamine agonist or MAOB inhibitor in order to enhance the patient's levodopa treatment. Another option is to increase levodopa action is the use of intrajejunal levodopa, also called Duopa. And there's some other medications that are currently in clinical trials, such as the subcutaneous levodopa, and some other more longer-acting levodopa medications, such as Rytary. And again, like I said, deep brain stimulation can also help in managing the patient's motor fluctuations. So let's talk a little bit about those rescue medications. This is Embracia, the inhaled levodopa. What's interesting about this medication is that it kicks in very fast and it's absorbed within 10 minutes. So if someone is very off, once they inhale Embracia, the levodopa, they are starting to notice improvement within 10 minutes. It usually lasts up to 2 hours, but not more. Just enough to bridge you over to the next levodopa dose. Patients can use Embracia as often as, or as many times as they're off, but not more than 5 times a day. Apomorphin. The ones that are currently in the market is Kinemobi, which is a sublingual and a film that goes under the tongue, and also the subcutaneous injections, Apican. Others that are currently on clinical trials is subcutaneous infusions and also inhaled Apomorphin. So Kinemobi is a film. It's almost like a Listerine film that you put under the tongue, and it dissolves and it starts working very fast. So we know that the studies, the clinical trials, have shown that it provides up to 3 times more improvement in the patient's motor symptoms, and clinical improvement is achieved within 30 minutes, and you can use it up to 5 times a day. If you look at the graph here, the line, the green line represents Kinemobi and the black dotted line is placebo. So if you compare the two, we notice an improvement of 15 points in the scale called UPDRS, which is a scale that we measure the patient's motor symptoms. So there's a remarkable improvement in the patient's symptoms with Kinemobi. Apican is also another option. It provides rapid and very reliable return to on state if the patient is off. It helps manage symptoms very quickly and ends off episodes. A lot of the patients use them first thing in the morning just to help them get out of bed until their morning meds start kicking in. It helps them walk, talk, and move around more easily, and also can be used up to 5 times a day. So this is what Apican looks like. And the studies showed that, again, compared to placebo, the solid line is Apican. It shows that there's remarkable improvement in the patient's motor scores, up to 25 points change from baseline. So again, within 20 minutes, you see improvement, and it can last up to 90 minutes. This is what the syringe looks like, with a very, very fine needle and very easy to use device. Another way to overcome off episodes, but is Redepilene. Nurians is the brand name, and it's not used as a rescue medication. It's once a day medication, but it has been shown to increase daily on time without dyskinesia. It's used as an adjunctive treatment to levodopa carbidopa. In other words, we take it together. If once the patient is on levodopa, we add it on, and it enhances carbidopa levodopa efficacy and it decreases off episodes. So overall, there's two doses, 20 and 40 milligrams. 20 milligrams have shown to improve off time by 1.35 hours, and 40 milligrams, the improvement is up to 1.45 hours. So we overall notice with one dosing of Nurians and improvement in off time. These are the data from the actual clinical trials. So we're seeing that compared to placebo, there's remarkable improvement in on time and change from off time compared to placebo. So less off time and more on time without troublesome dyskinesias. So this is also comparing the two doses. This is 20 milligrams and this is 40 milligrams. Again, change in on time and improvement in off time. Another class or category of medications are the COMT inhibitors. What we do know and have been using for many years now is Entacapone, also named or known as Comt, Stalevo, which is a combination of carbidopa, levodopa, and Entacapone, and the newer medication that has been approved for a year or so is Opicapone, which is known as Ongentys. So Opicapone is quite unique because it's dosed once daily, and it's a COMT inhibitor, and it's FDA approved for add-on treatment to levodopa, carbidopa, and it helps patients with treating their off time. It does inhibit the COMT enzyme, and that enzyme breaks down levodopa. So by stopping this enzyme, it creates more levodopa available to reach the brain. So Opicapone is a third generation COMT inhibitor. What we know is that half-life of COMT inhibition is over 100 hours. So that is why you can take this only once a day. And we have seen that compared to Entacapone, it provides more COMT inhibition. And these are the data from the clinical trials. We have seen that this is the comparison to placebo and levodopa. This is Entacapone and levodopa, and this is Ongentys and levodopa. So we see a remarkable improvement in off time. So there's a mean of 2-hour reduction in daily off time. And in the open label extension period, we see that patients who switched from Entacapone to Ongentys had almost 45 minutes additional increase in good on time. Another medication that we're very excited about and is not yet FDA approved, but on clinical trials right now, is IPX203-ER carbidopa levodopa. This formulation provides a rapid initial absorption of levodopa, and it then sustains levodopa plasma concentrations for an extended period of time. And compared to Rytary, most likely it will last longer by up to 1 hour compared to Rytary, and up to 2.5 hours or more compared to carbidopa levodopa IR. So if you look at the graph here, this is the IPX medication. This is the gray line is Rytary, and the red line is your regular carbidopa levodopa, also known as Cinnamon. So we see that the IPX203 tends to last longer than the other two. So almost close to 6 hours or more. So this is very exciting, and hopefully we'll hear more soon about this medication. Another formulation or type of treatment is the continuous subcutaneous infusion of carbidopa levodopa. This is not yet FDA approved, and it's not in the market. However, again, we're very excited as we see it go through FDA, and hopefully it will be approved soon. St. Elizabeth's was a center for the phase 3 trial, and we're really excited about this medication. So it is a subcutaneous continuous delivery of levodopa-carbidopa for the treatment of Parkinson's disease, and it treats on-time and motor fluctuations. Another subcutaneous infusion, an infusion under the skin, is Apomorphin. Also, a very exciting treatment option, not currently available, but hopefully coming soon. It bypasses the GI tract. It's very reliable. It can be used as rescue therapy. It also has a very short half-lifetime, and it is very well established for its tolerability profile. So these are some of the data analysis, the data we have from the clinical trials, which show a reduction in the off time and increase in the on time without troublesome dyskinesias. So the blue line is Apomorphin and the green line is placebo. So compared between the two, we do see that there's a remarkable change from baseline in improved motor symptoms and remarkable off time, so less off time compared to placebo. Another big part of mid-stage Parkinson's disease is dyskinesias. So we oftentimes are struggling with dyskinesias, and treatment of dyskinesias is key to improve the patient's quality of life. So we have a few medications that can help manage dyskinesias. Amantadine has been used many years now in order to treat dyskinesias. However, there's also a newer medication, a long-acting amantadine called Gocovri, which is also very helpful in treating dyskinesias. Another treatment option is to shorten levodopa-carbidopa intervals or decrease levodopa-carbidopa dose. Or we can decrease the dose and add a dopamine agonist. Or deep brain stimulation can also help attenuate and help with dyskinesias. So dopamine agonist is a class of medications. The most common ones used is pramipexole, ropinirole, the rotigotine patch, Apomorphin, and a newer one that is currently on clinical trials, Tovapidone. Tovapidone has been shown to help with dyskinesias and impulse control disorders. And it's once a day dosing, and it's a partial agonist of dopamine D1 and D5 receptors. And if you look at the data here, compared to placebo, again, there is a remarkable improvement in the motor scores from baseline. So this is the placebo, and this is the solid line is the medication. So there is an improvement with Tovapidone. I want to talk a little bit about wearables, as they seem to become more and more important tool to help clinicians treat patients better and optimize their treatment. So what do the wearables do? Over the recent years, we see that they've improved in diagnosis and rehabilitation assessment and in monitoring the patient's symptoms. When the patient comes in the office, we only see a snapshot of their symptoms, even when we examine them. However, we don't know what their life is at home and what their symptoms are during the duration of the day and night. So with the wearables, we can see the patient's motor fluctuations, the troublesome fluctuators, the dyskinesias, the off time, and we can really track the timing of these symptoms, the tremors, the stiffness, the slow movements, and make decisions on their therapy based on the data, based on what these wearables show us. It's a wonderful tool to effectively manage symptoms throughout the day and also throughout the night. This is something that we have started doing at St. Elizabeth's Medical Center, and it has been tremendously helpful in treating our patients. It also has been used numerous times in clinical trials and is still being used in clinical trials to give us information of improvement when we are administering the investigational drug. I'd like to spend some time talking about deep brain stimulation. Deep brain stimulation was approved in 2002 to treat motor symptoms of Parkinson's disease. It was approved for the indication of adjunctive symptomatic therapy in levodopa-responsive Parkinson's disease who are not well controlled with medication. Now, over the recent years, in 2013, there was a large study that looked at the difference between patients treated only with medical therapy or patients treated with deep brain stimulation and medical therapy. So the difference was very interesting in how those symptoms were managed. In patients who were on deep brain stimulation therapy and medications, we see that the improvement in their quality of life was remarkable. However, the patient who stayed only on medical therapy did not improve over the course of a whole couple of years. Other things that improved, other than the motor symptoms and the quality of life, was mobility, activities of daily living, bodily discomfort, social support, cognition were one of the things that the patients enjoyed better once they were treated with deep brain stimulation. Looking at some of the results, overall, a score that we used to evaluate quality of life, we saw a tremendous change from baseline in patients who received neurostimulation compared to the ones who only received medical therapy. So there was a 26% change from baseline in patients who received deep brain stimulation compared to the ones who continued medical therapy alone. So there have been some changes in the indications of deep brain stimulation. A few years ago, deep brain stimulation was recommended in patients who had advanced Parkinson's disease, and that they felt that medications was not helping at all. However, this indication has changed. What we now recommend is deep brain stimulation to be introduced in patients who've had at least 4 years of Parkinson's disease and over, but are not adequately controlled with medication, in patients who have motor fluctuations, side effect from medications, or dyskinesias for at least 4 months or even up to 3 years. These are the ones who are the best candidates. Not everyone can have deep brain stimulation. Unfortunately, there's a window of opportunity for DBS therapy. There's an optimal time after which you can no longer have deep brain stimulation because it may not be as effective and it may not give you the change in the quality of life that you would like. So the best time for deep brain stimulation therapy is in mid-stage Parkinson's disease, when you start having fluctuations, side effects from medications, off times, uncontrolled dyskinesias, etc. Very early, you're probably well managed with medication, so deep brain stimulation is not recommended. So it has to be somewhere in the middle. So what is deep brain stimulation? Deep brain stimulation is an introduction of electrical current into the brain. It's almost like a pacemaker of the brain. There's the implantable components, the electrodes, that are being placed deep inside the brain in areas that control symptoms such as tremor, slowness, and muscle stiffness. These electrodes are connected to a battery which is placed under the chest. You cannot see any of those implantable components because everything is hid well under the skin. And this is the external hardware that we use for deep brain stimulation. So there's the tablet that we program the patients, and also the patient programming device that the patient takes home and gives them control over their settings, and they can adjust according to what their activity level is, whether they're asleep, awake, or go to the gym, and if they have any changes in their symptoms and fluctuations throughout the day. Over the last few years, there's been a tremendous improvement in innovation in deep brain stimulation. We went from conventional electrodes or leads into directional leads, where we can actually direct therapy to a specific area in the brain so as to overcome side effects and optimize therapy overall. Other devices have appeared, and that each of them has a characteristic. Some of them use directional lead technology, wireless platforms, and even remote programming. So that was very useful in the COVID pandemic. And newer technology has been introduced called Percept, which is a brain sense technology that the device is able to capture and sense, so to speak, the patient's signals from the brain that correlate to the patient's symptoms. So you can capture when the patient has tremor, or when they have stiffness, or even when they have dyskinesias. So it can give us information that we use to optimize therapy. It's almost like an electronic diary. So we have been using this in the office to help optimize the patient's therapy. Percept is the only system which is eligible for a 3T and 1.5 full body MRI scans. It's a smart battery for personalized prediction of remaining battery life. It improves battery longevity. It allowed to make some adjustments and settings that we couldn't do before in the patient's therapy. And it also has a very easy to use patient programmer. The first one that was implanted in the US was in 2020 in Mayo Clinic in Rochester, Minnesota. So overall, what are the benefits of deep brain stimulation? DBS can improve your quality of life by improving motor function, by decreasing the amount of pills you take, by increasing the dosing and the number of pills you take, not only the amount. It can improve quality of life by up to 64%, so that's quite significant. What medication works 24 hours a day out of all the medication you're taking? Not many. DBS, though, does work 24 hours a day, so you can depend on less medication to control your symptoms. It also works when you're sleeping. That allows you to have less fluctuations, less motor symptoms, and less side effects from medications. The good thing about deep brain stimulation is that it's reversible. If you don't like deep brain stimulation, you can always turn it off. You can always turn it down. You can always take it out. DBS is also adjustable. As your disease progresses, your team can change the settings to continue to provide effective and optimized therapy. DBS is also renewable. If your battery drains, then you can always replace it with a very easy, low-risk outpatient replacement surgery. And we do know, all the studies have shown that the patients continue to receive DBS benefit for over 15 years after implantation. So I want to close with this slide of hope. Overall, we have 24 FDA-approved treatments of Parkinson's disease. That was not the case 10 years ago. We're getting better at therapy, different types of medications, different delivery systems, and the pipeline is extremely active. There's trials in delivery of medications, there's trials in looking at medications that delay the progression of the disease or disease-modifying treatments. There's trials of medications in novel mechanisms of actions There's trials of medication that target specific mutations that lead to Parkinson's disease. There's so much innovation in DBS therapy and devices. And we have so much coming in the wearables, where to help us understand the disease, help us understand the symptoms, and that way we can help our patients with optimal and optimized treatment. Thank you so much for your attention. If you would like to get involved in any of our clinical trials, please contact Caitlin Ramsey. This is our team, Dr. Hohler, myself, Keith Ciccone, and Caitlin Ramsey. Thank you so much.
Keith Ciccone is a nurse specialist working in collaboration with Dr. Vaou and myself. He evaluates individuals, does telephone triage, coordinates community resources and services, and also facilitates our deep brain stimulation program. He has almost 2 decades of experience working with patients and families with Parkinson's disease, essential tremor, epilepsy, and cognitive impairment. He has more than 13 years of experience in deep brain stimulation, coordinating pre- and post-surgery care, as well as deep brain stimulation programming management. Since 2005, Keith has served as co-facilitator for the American Parkinson's Disease Association monthly support group for Parkinson's disease patients with deep brain stimulation. Keith received his Bachelor's of Science in Music Therapy with a minor in psychology from Anna Maria College in Paxton, Massachusetts. He received his nursing diploma from Chelsea Soldiers Home School of Nursing. He was the recipient of the Outstanding Young Men in America Award, the Student Nursing Leadership Award, the Salvatore Esposito Senior Award from the American Parkinson's Disease Association, and the 2010 Chairman's Award. He's involved in numerous non-profit organizations, including serving as past president of the Massachusetts chapter of the American Parkinson's Disease Association.
Good morning, everyone. Today, we will be speaking on the late stages of Parkinson's disease. Parkinson's disease affects individuals different. Some people are diagnosed with Parkinson's early in life and remain in the early stages for years, while others could skip stages or rapidly progress in late stages. Regardless of how long it takes to get there, the late stages of Parkinson's disease will be disabling and a strain on the primary care giver as well as the family. In the late stages of Parkinson's disease, very similar to the other stages, but more visible bradykinesia, more rigidity, stiffness in the trunk limbs and extremities. They'll require more assistance in walking, standing, or could be the inability to walk. You may require assistance in turning in bed more frequently. You could have swallowing difficulties. You could be at risk for dehydration or malnutrition. When we talk about the late stage of Parkinson's disease, we want to make sure that the medication management is taken care of and that we're compliant with medication. There are options for those with pill pack, medication cassettes, or even there's an automatic pill dispenser from Philips. You may need your family member to help you to make sure your medications are delivered in a timely fashion and accurate. We also recommend that you do a medication spreadsheet. Maybe you have already done this, or maybe you can have a family do that for you. We want to make sure you have the name of the medication, the strength, the instructions, the prescribing doctor, and which pharmacy the medication is being filled. Swallowing difficulties can occur at different stages, but at this point you might have more problems swallowing the medication or with fluids. We will ask you during your visit if you have any problems with textured foods, medications, or any thin liquids such as coffee, water, juice. And medications that were given in pill form in the beginning may need to be crushed or may be switched to a liquid form. Difficult swallowing involves problems in the brain, peripheral nerves, and muscles. It may involve a lack of coordination of the muscles and the reflex in swallowing. Food can get caught in your throat, and some people may pocket their food. Food or liquids can leak into your lungs and cause pneumonia. A speech evaluation might have been done in earlier stages, but we may need to require another speech evaluation to ensure the proper diet and if a thickening agent may be needed for liquids. During the late stage of Parkinson's disease, you may see some weight loss or dehydration. Weight loss is common in Parkinson's disease. This is mostly seen during advanced stages, and this should be addressed during a clinic visit with your movement disorder specialist. It can lead to malnutrition and worsening of PD symptoms if not contributed. Contributing factors to weight loss include dyskinesias, depression, loss of smell, constipation, or swallowing issues. We also want to make sure that we have evaluated the labs and thyroid conditions, and we also want you to consider working with a speech therapist, a thickening agent such as Thicket. We may recommend eating smaller meals more frequently, maybe 6 small meals per day, eating softer foods such as mashed potatoes, or it could be squash, or it could be something softer for you to eat easily. You may have to avoid things that are stringy nature, such as maybe mozzarella cheese or foods that may get caught in the throat. Changes in diet consistency may occur at this stage. We may go from a regular diet to ground diet to soft or puree. We also recommend that you ask for your favorite foods, whether it be sweet or salty, or maybe that favorite meal that your wife or spouse cooks for you. You might want to consider supplements, and that might be a recommendation that is done by your movement disorder specialist, such as Ensure or Boost, and there's other agents such as Ensure and Boost pudding form that may be a better choice for you. Medications during this stage may be adjusted by your provider from liquid, crushed, or a patch as needed, but the medications may need to be looked at according to where you are with your weight at this point. During the stage, we may have changes in bowel and bladder. Bowel and bladder issues stem from problems with the message getting from your brain to your bowel or bladder. You may have an overactive bladder. You may have stress incontinence when you laugh, sneeze, or cough. You may have frequent urination during the evening. You could have a weak urine stream. You may have constipation or diarrhea. You could be incontinent of bowel or bladder. You may need to wear adult underwear. And we want to make sure that during that stage that you make sure you have proper hygiene care. And we also recommend that a barrier cream to prevent any skin breakdown. These are things that may happen, not saying they will. So we give you an overview of anything that may happen during the late stage. Changes in your thinking and behavior. Parkinson's disease can disrupt the part of the brain that controls your thought and memory. You may have trouble concentrating. You may have poor judgment. You may be a little impulsive, like getting out of a chair and when you might not have your walker in front of you. You may have hallucinations or misperceptions or seeing things that are not there. And that's concerning to us as it could be a medication side effect, or when those things happen, it could mean that you might have an infection. So when those things occur, we do want you to contact your movement disorder specialist, especially if it's sudden onset. You may have delusions. You may become irritable just because of things that you were able to do previously and no longer able to do. In Parkinson's disease, people do have anxiety. Also, with the changes in cognition, at some point during your stages, you may have had a MOCA or a neuropsychological testing and may have been recommended to use a medication such as Percept or Namenda. We also may recommend a psychiatric evaluation for cognition, anxiety, or medication management. During Parkinson's disease late stage, sleep disturbances are common in people with Parkinson's. We have people that report to us trouble falling asleep. You might have a nightmare or vivid dreams. You may have REM sleep behavior disorder, as I was discussed maybe earlier, which is acting out your dreams. You may have restless leg syndrome, and you may have been undiagnosed with sleep apnea. Frequent nighttime urination is very disrupting to your sleep. You may be up from 1 to maybe multiple times during a night. And there could be some confusion at nighttime, maybe getting your days and nights mixed up. We do recommend a sleep specialist evaluation, and that could have been already done in an earlier stage of Parkinson's disease. Living environment. Changes occurs when the people choose to stay in your home, especially if you have rugs, large furniture, a two-story home, small doorways, or years of accumulation. Some people may say, move, which is always easier said than done. People may say declutter your home, and you could just be overwhelmed. You and your spouse or your significant other could be just overwhelmed by decluttering a home. Today, there are many organizations out there and companies that will come and help you do this. Move to one-floor living. We can either have you move to an apartment or a one-floor home, or you can just move your belongings from the second floor to the first floor, so you're just only living on your first floor. You may need to add a bathroom or a handicap bathroom to your first floor. There are other communities available, such as a 55-plus community. There are also facilities that are called assisted livings or continuum care living facilities that have assisted livings up to long-term care. During this stage, you may need equipment in your home. You might already have a walker or a wheelchair, but we might need a bedside commode. You may need a full electric bed, including side rails, a gel mattress, or trapeze. And that may be done during an office visit to see if you need that done, as well as you may have to work with your insurance company to ensure the way they do their process. There's also equipment such as stand assist patient lift. You may need a urinal, incontinence supplies, mouth swabs, adult wet wipes, disposable gloves, or even suction equipment. You may need some or part of all these, but again, we want to make sure that you understand that's something that you need to prepare for the future. During this state, or maybe an earlier stage, we need to ensure that you have proper estate planning. It's important for patient and caregiver, and it's understanding whoever you choose, they have an understanding of the Medicare, Medicaid, disability, and veterans benefits. We want to make sure that you understand the medical and legal terms that they talk to you about. If you do not understand what they're talking, or if you please ask them to repeat them, and we do recommend a family member does accompany you during these visits. They'll be able to talk to you about a healthcare proxy or a power of attorney, advanced directives. There's also a booklet out called 5 Wishes, which you are able to express your wishes in writing. And some attorneys do recommend to review your estate plan annually to make sure everything is in its proper place. At this point, we might need support. Besides your primary caregiver, you may need the support of your family support of nieces and nephews, children, great nieces and nephews, or close family friends. You may need an adult day health program. You may need private help, which is usually not covered by the insurance. And that's a cost that each of us may have to incur during a late stage of Parkinson's. You should have reached out to the Council on Aging to see if you qualify for home health aides or Meals on Wheels or any other community services that might be available to you. If you're a veteran, we want you to contact the Veterans Administration Office. If you qualify, you will speak with the VSO or Veteran Service Officer in your town or city hall. They should be able to help you to see if you are entitled to services underneath your veterans benefits. Insurance options. Some insurances may offer PCAs, but every insurance is different. So that's a time that you might want to speak with a customer service rep from your insurance company. Some religious organizations have what they call as pastoral nurse ministry. You may want to see if your church, synagogue, or religious organization has something similar to that. At some point in life, you may have taken out long-term care insurance. We know that long-term care insurance is usually done prior to any diagnosis of Parkinson's disease. And if you do have this benefit, you want to contact your long-term care insurance to understand how that benefit is implemented. Assisted living facilities may be an option for you, or at some point you may need to have a long-term care facility, also known as a nursing home. During the late stages of Parkinson's disease, you may be talked about palliative care. It is a treatment to manage pain, symptoms, and side effects of chronic illness. Patients receive palliative care at any stage of their illness and can contribute to pursue curative treatment. A referral is usually made by your movement disorder specialist or a primary care doctor. Some people do transition from palliative care into hospice. Hospice may be known to all as a philosophy of care that focuses on providing physical and emotional and spiritual support intended for you as the patient and family of a terminally ill patient. A referral, again, is made by your primary care doctor or movement disorder specialist. Hospice care can be given in the comfort of your own home, in assisted living, or in a nursing home. There are also hospice facilities that are able throughout Massachusetts and the United States. And we know that caregivers have a huge responsibility and try to keep it all organized. Whether you be the primary caregiver or a child or a niece or nephew or a friend, we recommend like a 3-ring binder. And in that, we recommend that you keep that in a safe place, next to the phone if you still have a landline, or maybe next to the main door. So in an emergency situation that everything is needed could be taken to a hospital or an urgent care. We want a copy of the ID, such as a license or a photo ID, a copy of your current insurance card, a copy of your social security number, or at least know the numbers, a copy of all emergency contact names, relationships, and their phone numbers, name of all physicians, specialty phone numbers, and hospital affiliations, a copy of your healthcare proxy, a copy of your most current medication sheet, which should be updated after each visit to all your providers. You may want to send that to your smartphone as well as share it to a family member as appropriate. This concludes my talk on the final stages in the late stages of Parkinson's disease. I hope this has been helpful to you. If you have any further questions, there'll be a slide at the end that will discuss how you can contact our office. Thank you so much for your time today.